Hi, good evening, everybody. How are you all doing? So we're doing something really different tonight. We have MS NeuroTV live. Okay, we've never done this before. It was always like a pre-recorded version, and then we had the doctor or the nurse practitioner or whoever else was speaking that came on afterwards, after the dialogue, the pre-recorded dialogue, and then that person was there to answer any questions. But tonight we're doing something really, really different, and we have Dr. Aaron Boster here. And you know me, I mean, it's right there on the screen already. You can see who I am, although tonight it looks like I have less hair. And so we're going to get started with this program. And you can see also we are supported tonight by Biogen and Bristol-Myers Squibb. And what's going to happen here tonight is that Dr. Boster is going to speak about MS 101, a little bit about that, then about the COVID risks and risks of exposure, like during family get-togethers. All right. And then he's also going to talk about the vaccines. All right, and then we're going to get into questions. So let's do this. Let's get started. Let's let Dr. Boster, you all know him. I mean, yeah, who doesn't, right? So let's let Dr. Boster get started, okay? See you all later.
Howdy, and thank you so much, Stu. My name is Aaron Boster, and as always, thank you for learning about MS with me. I'm delighted to be here tonight with MS Views and News as we do MS NeuroTV. I want to thank Biogen and Bristol-Myers Squibb for making this a possibility this evening. I'm going to be talking to you about some very contemporary topics. I wanted to first, however, kind of level set education about what is MS. Sometimes we overlook that, and not everybody's on the same page. So with that in mind, I want to spend a minute or two talking about what MS is. And really, to understand MS, we have to first understand the immune system. Now, the immune system is a bunch of little white blood cells made inside the bone marrow, and they're released into the bloodstream, and they're like college freshmen. They have no idea what they want to do when they grow up. Now, these unclear, virginal, naive white blood cells, they go to school up in the thymus at what I like to call T-cell university. Now, T-cell university is a very weird school. First of all, it's free to get in. There's only one class. And that class is, can you differentiate self from non-self? So if I show you a foreign invader, if I show you a virus or a bacteria or a fungus or a parasite, can you identify it as a foreign invader? Or if I show one of your own cells to you, do you identify it as such? Now, when you go to T-cell university and you graduate, there's only one occupation, and that's soldier, literally. And so we give all the graduating cells weapons, and they tool around the human body. Now, when the cell sees a self cell, it says, hey, me, nice to see me, you look good. And when the cell sees a foreign invader, it stops what it's doing. It gets out its iPhone 11 and takes a picture of the virus, and it sends it to all of its friends. All its friends gets together, and then they stomp on the virus to death, and they clear the virus out of your body. When someone tells you that you can't get chickenpox twice, they're lying, because that first time you were exposed, your immune system built an arsenal against the chickenpox. You can get chickenpox a second time, but you won't know it because that arsenal, that immune response was there, and it pounced on it and cleared it right away. Let's go back to T-cell university. What happens at T-cell university if you fail the class? Well, remember I told you it's a weird school. It's free to get in. There's only one class. But if you can't differentiate self versus non-self, they take you out back and they murder you. It's pretty serious stuff. Only the cells that are able to differentiate are allowed to continue. Every once in a while, though, the immune system messes up. And at T-cell university, they have a kid that fails the class and they forget to kill him and they graduate him. And now he's a soldier and he has weapons and he's tooling around the human body with all of his friends, thinking he knows what he's doing, but he doesn't. And he sees part of you, but he thinks he's looking at a foreign invader. So he calls over his friends, he takes a picture, sends it to everyone, everybody gets together and they stop what they think is a foreign invader. And that's actually part of yourself. And that's called autoimmunity. And there are a bunch of autoimmune conditions, and you've heard of many of them. For example, diabetes is an autoimmune condition where the immune system attacks the pancreas, and then you don't make insulin. Rheumatoid arthritis is an autoimmune disease that affects the joints. Psoriasis is an autoimmune disease that affects the skin. Multiple sclerosis is an autoimmune condition as well. It's the situation where the immune system attacks the holiest of holies, the supercomputer that runs the body, and the spinal cord, the superhighway that takes all the information from the brain down to your feet and back up. And multiple sclerosis is a situation where the immune system learns something wrong and it doesn't stop. And each time it does its tour of duty and sees that part of you, it risks attacking it and causing brain and spinal cord damage. Now, I wanted to go through that preamble of what MS is so that I can shift topics on you and I can talk about COVID-19 as it relates to people impacted by MS. We are living through a global viral pandemic. I'm broadcasting tonight from my hometown of Columbus, Ohio, and there is a spike like we have never seen in this state. The number of deaths are in double digits each day, and it's absolutely terrifying. And in the last 3 weeks, I have seen more patients exposed and contracting COVID than I've ever seen in the last 3 months. It's a really scary time. Now, COVID-19 is a coronavirus, not the beer, but the family of viruses, coronaviruses. It's like influenza viruses. Coronaviruses are a family of viruses. There's actually hundreds upon hundreds of them. And they've been around for a long time. In fact, they've been around longer than humans. And there are specific coronaviruses that infect humans and typically cause stuff like the croup or the common cold. And so you have probably had a coronavirus infection in the past. What we're dealing with today is different. It's a novel coronavirus, a coronavirus that previously only lived in other mammals, and it jumped species. It's called a zoonotic infection. And we became infected with this unusual variant that we've never seen before. It's highly infective. And so it's spread literally around the globe. The term pandemic is not used colloquially. It's not a marketing term. It's something very specific that tells you that this is spread everywhere. And a global pandemic means there's no place to hide. And that's where we are right now. Now, much to my chagrin, our country has failed in trying to control the virus, and it's now extending exponentially, and that's what you see when a virus goes unchecked. And so, as you can only imagine, there's a lot of questions in clinic about COVID-19 as it relates to multiple sclerosis, and so I would like to talk a little bit about that now. But first, a quick sip of this apple juice. It's good. Now, when we talk about the risk of coronavirus or the risk of COVID-19, we have to clarify there's actually two separate risks that we need to discuss. The first is the risk of contracting COVID. Now, the risk of contracting the virus has nothing to do with having MS. It has nothing to do with taking an MS medicine. It actually has nothing to do with a future vaccine. It has everything to do with coming in contact with someone who has coronavirus. Now, you can have coronavirus and it is asymptomatic. It's kind of cultivating and building up in your body for a period of 2 weeks before you start to have symptoms. And particularly in children, there are increasing cases where people don't really have symptoms. They don't really understand that they've been infected. And yet every time they talk, the way I'm talking right now, they're spewing respiratory droplets 6 to 8 feet in the air, and it's coming in contact with surfaces that people are touching and then touching their face, or it's coming in contact with people's faces and they're infecting those around them. And so when you think about the risk of contracting coronavirus, there are several things that we want to do to mitigate that risk. What are they? Number one, wear a mask. Wearing a mask prevents you from spewing your respiratory droplets, and it prevents you from coughing or sneezing and really pushing that stuff out in the room. And if you wear a mask, you do protect yourself somewhat from respiratory droplets coming in, but it's mostly helping others, keeping your respiratory droplets out. And if you're wearing a mask, you're helping everyone in the room with you, and they should be wearing a mask to help you. I will not see someone in my clinic unless they're masked. And I want to make a particular point. Masks that you wear like this don't work because you still have access to your nose. And you need the mask to be up over your nose to be effective. Recently, there was a paper that showed that frontline medical staff who wore glasses came down with less coronavirus infections than those that didn't. And that's probably because if you don't have glasses and someone coughs and you're wearing a mask, it can still get in your eyes. So if you're bespectacled like I am, it's actually protective in some respects. And when I'm seeing patients in clinic, I'm starting to wear a mask and a shield to protect myself. The second thing is to wash your hands. And I bring this up to you because even though this has been going on for 8 months now, it's so critically important that we don't become tired, fatigued, and say, I don't really need to do that, because you do. We know that the coronavirus, COVID-19, can live on surfaces. And so if you touch a surface and then touch your face, you're going to risk infecting yourself. And if you sneeze on your hands and you have coronavirus and don't know it, and you touch a doorknob, you're going to give it to somebody else. And so sanitizing your hands or washing your hands with hot water with soap for 20 seconds is a really important thing to do. The third thing that we need to be doing to minimize our risk of contracting COVID-19 is we need to spend time away from others. And this is so hard right now. It is so hard because we are engaging in one of our most awesome national holidays. Tomorrow is Thanksgiving. And traditionally, we get together as families, as small communities in people's homes, and we celebrate and we laugh and we eat, and sometimes we drink and we have a great time. And this year, that's not safe. This year, I had to tell my 71-year-old mother that I wasn't going to come to her house for Thanksgiving. And she didn't take it great at first. Then we talked about it for a while, and she finally said, if my son, the doctor, thinks it's that important, it must really be that important. And I said, Mom, thank you. I explained to her that I love her dearly, and I don't want to risk getting her or her husband sick. And so we're going to stay at home this year with my children and my wife alone in our home, and we're going to Zoom my mom, and we're going to be able to interact with her that way. And that's not ideal. And I'm really bummed out because my mom makes turkey like no one else's mom, but we're going to have to do that next year. It's a tough time, but keep in mind that in the state of Ohio, the spike in COVID cases, which has gone through the roof, has not occurred because of big social events, because there aren't any. It's occurred when we track it back with small social gatherings in people's homes. We're talking about a small reception after a small wedding, or a funeral reception, or a party. We need to not be doing that right now. It's so important. Now, I want to shift gears yet again, and I want to talk to you about vaccines. But first, another sip of apple juice. Oh, that's good. So it's extremely exciting that it looks like there's not one, not two, but 3 vaccines that are on the horizon to treat and to immunize against coronavirus. And that's a revolution, because we've never been successful in the history of humankind making a successful vaccine against the coronavirus family. And so the fact that we may very soon, as early as the middle of next month, have 3 vaccines is phenomenal. And if you have any insights into how challenging it is to develop a vaccine, it normally takes decades, and it's been done in months. That's heroic. There's a lot of questions in clinic about the coronavirus vaccine. Is it safe? Can I take it? When should I take it? What about mine in shot? What are the side effects? And the stark reality is we don't know a lot of information. Now, when I can get a hold of it and I can read it, I will do YouTube videos. I will do live streams. I will be talking to every patient in my clinic. And we're on the cusp of learning that information. And we believe that the coronavirus vaccine will be dead, and it should be safe for people impacted by MS to take. And I think there's a very, very high likelihood that I'm going to strongly recommend it, not just for me and my staff and my family, but also for you and your family, and for my patients and their families. And I want to spend just a couple more minutes talking about vaccines in general to help you understand the importance of this. The way that you make a vaccine is you take a virus and you put it in the blender and you shred it into a bunch of pieces. And just as an example, let's pretend that this piece of paper is a virus. And so we put it in the blender and we rip it up into a bunch of different pieces. All right, so now we have like blended pieces of a virus. And then what we do is we load it up into a syringe and we inject the little tiny microscopic viral particles into your body. And then your immune system sees these tiny little fragments of the virus, and they may build an antibody against that curve. So now you're going to build an antibody that identifies that small portion of the virus. And then you'll have a separate antibody that will build against that arc right there. And your immune system will develop an arsenal that can identify different parts of the virus. Then later, if you come in contact with the virus, you have all of these antibodies that are there waiting to pounce on it, and your body will be able to clear it. And that helps not just you, it helps you and it helps your community, your village. So let me explain. If we immunize you and then somebody coughs on you and gives you coronavirus or COVID-19, you're going to have the immunity to fight it off. And so that's going to help you, which is super awesome. But if enough people get immunized, and it really needs to be like 90%, if enough people get immunized, then we're going to do something very different. We're going to eradicate the virus. We're going to make it go away. We've done this successfully with other infections, like with measles and mumps. We have essentially gotten rid of measles by vaccinating everyone. And unfortunately, in areas of the world where people in small communities are saying no, those small communities, you're seeing an uptick again of measles. And if enough people take coronavirus vaccine, COVID-19 vaccine, what will happen is that the virus won't be able to find a host. It'll bounce from person to person and they'll all be immunized and the virus will die. And the reason this is so important is for the people that are at highest risk. People that are older in age, people that have cardiovascular risk factors, people that have other comorbid conditions who are at high risk of a very severe outcome with COVID will be protected because we're going to kill virus and they won't get to them. And so that's super important. My name is Aaron Boster, and I want to thank you for taking a few minutes to review the MS 101, also to talk about the risk of contracting COVID-19, and then talking about the very near-term future of vaccines for people impacted by MS. Stuart, I'm going to turn it back over to you and we can open up the lines.
That's great. That's great. I just wanted to show people the right way to wear a mask, and I love wearing my masks. So, I have like a different mask for every shirt that I have in my closet. So that's nice. A great thing.
It's like a tie.
Right, which I don't have on tonight. So, I feel strange with that. But listen, people don't want to hear about that. First off, thank you very much for giving this discussion. This is exactly what people need to hear. This is exactly what a lot of people were asking about last night when we did our patient perspective program. And in fact, there's a person on, she just left a comment. She was on last night as well, and that is Stephanie. And she writes that it's so very good and clearly explains the virus. Okay, so I wanted to just let her know about that. By the way, if anybody's here and they just want to make comments, you can. It doesn't have to be questions. I'm just going to say your name and give it out. All right, but again, we do have a lot of questions. And by the way, Dr. Boster, Pfizer made an announcement earlier today, I believe it was earlier today, that they do obviously believe and they do want everybody to get the vaccine. But they were also saying that they have no idea, though, that even a person, if that person is vaccinated, if that person could still be a carrier or not. And so, that becomes an issue. And how would that person not be a carrier is exactly as you were saying, everybody around has to be vaccinated. So
it's beyond important, Stuart. Herd immunity or herd protection is the way that we're going to save hundreds of thousands of lives.
That's true. Very true. So another thing came up recently, and it was on the news, and a person just asked it as well. I don't know if you heard, but in Russia, they are preparing a vaccine for mink, for the animal mink, because they believe that mink are spreaders of this virus. And,
Wow.
Nobody understands how, but that's what they're studying. So
wow.
Somebody here now asked if will dogs and cats, will be part of this as well. And this comes from Pamela. So will dogs and cats harbor the virus?
I don't know the answer. I have seen a couple reports that maybe dogs can carry the virus, but I don't know that. And it just highlights the fact that we are living science as it moves forward in time. It's one thing to already know a bunch about a virus like chickenpox, like shingles, varicella. We know a lot about that virus. We know where it spreads and where it doesn't spread and how to treat it. And that's because we've been dealing with it for centuries, decades that we've been aware of it and treating it. Here, this is new as of essentially the end of March of this year. And there's so much that we still don't know.
Right. So Jill sent in a question. Have you heard anything about the vaccines in young children? I heard it will not be available.
I don't know the answer, and if I was to make a guess about public health, I would want to immunize the people that were at highest risk, and that would really be two cadres of people: healthcare workers, particularly frontline workers, and people with chronic conditions that may be at higher risk, and folks that are a bit older in age. Those would be the two big populations that I would want to hit first. And then I would try to get the rest of the population. And that's just my own conjecture. And I'm not a public health specialist. I'm just sharing my opinion as an immunologist.
Right. So when you say people at higher risk, does that also mean people that are using immune suppressant medications, like some of our MS drugs? I mean, so not everybody's using an MS drug that's an immunosuppressant, but for those that are, do they then fit into that category?
I want people to assume that if they're on an immunosuppressant drug, and there are plenty in MS like Limtrada, Ocrevus, there's functional immunosuppressants like the Gilenya and Mayzent, and these are medicines that alter the immune response in a way that can cause suppression. I want us to imagine that they're at increased risk, because that's the level of safety that we need. Now, the reality, Stuart, is that we're not exactly sure. And I'll use Ocrevus as an example, which is a B-cell killer. There's some data that it may increase the risk of a more severe infection. There's other data that in the absence of comorbid risk factors, not so. And what do? Well, I want to behave as if it increases your risk, because that way we're being as safe as possible.
Right. So again, though, and thank you for that, but Cindy is asking, are people with MS at risk at all, or are they at higher risk just having MS?
Not having MS by itself does not increase the risk of contracting COVID, and MS by itself does not increase the risk of a more severe infection, with one caveat. If you have very advanced MS and you can't move very well, so you can't move your arms and legs, it's hard to easily take deep breaths, then you would be at increased risk. But barring that, no, you're not at increased risk just because you happen to have MS, and you're not at increased risk of a more severe infection just because you have MS.
Great, thank you for that. All right, so the next one, and I'm just shooting through all these online questions first. And again, we have a lot on paper, but I do know we need to be done by 9 o'clock, so let's try to keep everything as short as possible, okay?
I'll try. Not my strong suit, but I'm going to try.
I truly know that, okay? I really do know that. What happens if the soldiers in your body don't recognize the coronavirus?
So the idea is to teach them, to train them, to send them to basic boot camp by giving them a vaccine where you shred the virus and show it to them and let them learn about it and build an arsenal against it. So we're really going to teach the soldiers what they need to attack by immunizing you.
Great, great. Okay, next one, Karen writes, what about Ocrevus and vaccine not being as effective? Better to go Mavenclad a few years, tricky taking vaccine with infusion.
So that's a very good question. And here's the way I answer this. I borrow information from vaccines for other infections, right? Because we don't know yet with the coronavirus. But what we do know, and I participated in a trial called the Veloci trial, where we had someone with MS who took Ocrevus, and then we gave them a vaccine for DTaP and our MMR and et cetera a month later. So what we found was those people mounted a response. They mounted an immune response, but it was attenuated. So it wasn't a full response. It was about 50 to 70%. Now, if you take a vaccine a month prior to Ocrevus, it works 100%. And so ideally, you would immunize someone for COVID-19 a month before their infusion with Ocrevus. But if you can't, my plan is to immunize them anyways, because based on the data from other vaccines, it should still work. And then if they don't mount a full response, when it gets time, a month before their next infusion, I'll just immunize them again.
Okay, thank you for that. Barbara writes, do you trust the vaccine with so few trial participants?
Barbara, it's not so few. If you look at the number of people, we're talking about tens of thousands of people that have been, so it's not small at all. It's actually huge. And to answer your question, I do trust it. I will have my son Maxwell and my daughter Betty I will have my wife, Chrissy, and I will take the vaccine. That's how committed I am to it, is I'm going to subject myself and my family to it. And I'm going to strongly recommend that you do the same.
And as I mentioned last night, for those that were with us, I said I too would do it because I don't want somebody saying that you can't travel anymore because you weren't vaccinated. Okay. And I do need to get out there and travel and bring our educational programs around the world. And the sooner I could get vaccinated to do this, the sooner we could get started doing that again too. So yes, I'm not going to have a label put on me that's he wasn't vaccinated. Put him in the back of the line, bury him in the back somewhere. Okay. Katerina, she writes, if patient is getting monthly IVIG for MS, can they get the COVID vaccine? Would it be effective?
That's a really awesome question. When you take IVIG, you're dumping hundreds of thousands of donor antibodies into your body, and it binds up to your autoantibodies and clears them out. And so, yes, you can take a vaccine. You're just going to have to be timing it right. And so if you get a monthly vaccine, what I might do in my clinic is immunize you and then try to wait a little bit before I give you your next dose, if there's any wiggle room. But it can be done. You just may have to manipulate the timing a little bit, and your doctor should be able to do that with you.
Great. Thank you for that. Now we're going to take two more questions about COVID, and then, you know, we have more to life than just COVID. We have MS, right? So we have MS questions out here too. So the next one actually is not a question. Rocio writes, thank you so much, Dr. Boster. All information was really valuable. Makes me feel at ease with what you said about the vaccine. So thank you, Rocio, for that. We do have another question. It's actually, we have a whole bunch. I didn't even see these come through again, but we're going to hold off on the ones online a little bit. And let me get to the ones that we did have on paper. All right. First one being, how does diet affect multiple sclerosis?
So that's a very popular and important topic. When I was coming up through the ranks, I was told that you should take a vitamin D supplement and a multivitamin, and the rest of it didn't matter, and that was not accurate. Turns out that we can impact symptoms by changing our diet. I don't believe that you can slow down MS by adhering to a particular diet. The data doesn't really support that. So when people tell me that they're going to start this protocol or that protocol, there's nothing wrong with that as long as it's not dangerous, but I don't want them to have a false understanding that they can slow their disease down, because that has not been proven. But anecdotally, what I absolutely believe to be true is that through efforts of diet, you can decrease fatigue, you can decrease depression, you can decrease cog fog big time. Why do I say that to you? Because I've seen it time and time again. And let me give you my secret pro tip, which is not secret. I recommend that people impacted by MS eat real food, not fake food. So fast food is not real food, it's chemicals. And soda pop is not actually food, it's just a bunch of chemicals. And if a food item has a bunch of ingredients that you can't pronounce, I don't want you to eat it. I want you to eat things that have ingredients like apple, asparagus, chicken, stuff like that. And that's very important. I recommend that you avoid sugar-laden foods, fried foods, heavily processed foods, and I double dog dare you to try it for a month, because what you will find will rock your socks. You cut sugar out of your diet and you have bounding energy. It's really kind of awesome. Try it out.
Great, thank you. Now there's a question on paper that's also written right here online, so it's easier for me to read what's in front of me. And Bruce writes, a lot of MS patients have fatigue, brain fog, walking problems, gait issues. Now with COVID, some COVID patients have long-term effects of fatigue, brain fog, and the other issues, which he's saying is called chronic COVID. Is that a word that's out there, and can you explain that?
Yeah, so as people survive COVID, some of them clear it and they're back in the game. Kind of like with a flu bug, you know, where you're sick for a while and then you get better and then it was a past tense conversation. But that is not true for all people. And I have many patients in my practice that have what we would probably refer to as chronic COVID, where they've cleared the infection. They're not at risk of infecting other people, and they're no longer at risk of losing their ability to breathe. but they're not back to normal, and they have some residual symptoms. I've had patients today in clinic that shared they ache all over. They're just completely achy, and they're fatigued in a way they haven't been for quite some time. They said it was like when they were first diagnosed with MS before they got on a stimulant. And this has been reported. And so I think, again, this has been a baptism by fire. This just started in March of this year. And so there's a bunch that we still don't know about this virus, but that is a term and that is real.
Great, thank you. How important is it to continue receiving physical therapy and occupational therapy treatments at this time?
In a word that I'll say 4 times, really, 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 really important. It's super important. And managing MS, you know, when I talk about being 4 for 4 in your fight against MS, one of those 4 things is to exercise as part of your lifestyle. And some of you are familiar with the allegory of the guy that had to roll the boulder up the hill. And as long as you keep pushing the boulder up, he could go up. But when he stopped, it rolled back down. That's multiple sclerosis and exercise. And if you quit your efforts of exercise and stop participating in physical and occupational therapy, you're going to risk backsliding. And so it's really important. Now, how have we gamed that out during COVID? Some people have been uncomfortable or unsafe leaving their home. And so we've had to come up with home exercises. Some people have allowed home health physical therapists to come in the house, and some people have gone into physical therapy suites. So we have to be creative, but it can be done.
Great, thank you. All right, how many years does a person need to stay on MS medications or other therapies?
So MS disease-modifying therapies should never be continued after death. So when you die, we should not give you an MS therapy ever because they've never been studied in death. They don't work, to my knowledge, in death. And a lot of the treatments, they require your bloodstream to circulate, and if your heart's not pumping, they won't go anywhere. So I also am unaware of any ongoing complications or attacks of MS after death, so it might not be necessary to treat. But prior to death, I want to treat you. Here's why. Your immune system may get quieter as you get older, but it doesn't turn off. And if you have an immune system which is attacking the holiest of holies, the supercomputer that runs the body, you risk losing functions. So if you have a nervous system which has functions that you like swallowing, seeing, having an orgasm, enjoying the taste of something, walking, I want to keep those things for you as long as possible. There was a recent study published which looks at advanced multiple sclerosis folks in a nursing home who are really bad off, very disabled, for 2 years, and they were all off therapy, and they all progressed in their disability off therapy. My point here is we need to not ignore MS because you're a certain age. You know, say, oh, well, you made it to 55, so you had a good life, so good luck. That's not the way I want to do this. And we have good evidence that when you continue to treat, you slow the trajectory of the disease. So I want that for you. And I would not stop treating you until after you die, and then I would stop treating you.
That's a great answer. Thank you for that. I hope everybody understood that part too. So going forward,
it just doesn't work after death. It's not a smart idea. It's not medically savvy to do that. Prior to death, it's very medically savvy to treat.
Well, after I die, I don't know if I would recognize the difference either. Right. Okay. So Mike says, Dr. Boston mentioned eating fresh food, fruits, chicken, etc., to improve energy. I do. Plus, I work out 6 days and I still get tired. What am I missing?
So if you stopped eating healthy and stopped exercising, you would be more tired. So I assure you, my friend, you're helping yourself a great deal by what you're doing. Now, I'm not saying that if you eat right and if you exercise, you'll never have any energy problems because you still have multiple sclerosis. And the most common symptom in MS is pathologic fatigue, but there's more that we can do. You know, I think I recently in the last month made a YouTube video and I listed over 70 different contributors to fatigue. So poor diet is 1, lack of exercise is 2, so there's 68 others that I listed on that video. And so you might check that out and look for other things that you can do. But I assure you that by your diet and your exercise efforts, you are helping your energy levels. And I would hate to see how bad it is if you didn't do that stuff, because I would hypothesize it'd be really bad.
Thank you. So there are a lot of people that are always saying tired when I think they mean fatigue, or they use fatigue in the wrong manner as well. Can you briefly, within 20 seconds, give them the difference?
Being tired is a casual English term, which means I would like to take a rest. When we talk about pathologic fatigue in MS, we're not talking casually, and it's actually the leading cause of loss of work amongst people with MS. It's a devastating phenomenon, which I can only attempt to describe by suggesting that you skip 2 nights of sleep and then go on a walk. That's the kind of fatigue that my patients describe to me. And I'm excited that I crammed 20 seconds into 30 seconds.
Exactly. Thank you. All right. Next one. Person writes, can stress cause fatigue?
I think that stress can exacerbate fatigue. Nobody goes home at night and says, honey, let's get stressed out. That's not a conversation that you have with your spouse. And I don't think that stress can cause fatigue, but I feel strongly that stress can worsen or exacerbate fatigue.
Great. Thank you. All right. Here comes a goodie. We haven't heard this in a long time. Person asks, do you have any recent info on Ccsbi?
Yes, it is dead. We put a nail in the coffin. We put it in the ground inside of a cement casket. We put a lid on the casket, and we each took turn dumping dirt on top of it until it was all the way up. And then we planted grass on top of it. And then we had a tombstone that said, stop talking about something that doesn't work and cause death, because we've proven it doesn't work. And that's what the tombstone reads.
That's right. Good. Good answer. All right. What are some things to help with constant urination? What therapies are available for MS incontinence?
So constant urination and MS incontinence are 2 different things. Incontinence is the doctor term for I peed my pants. Constant urination is when you're constantly urinating nonstop. And so I'm going to assume they actually mean incontinence, Stu, and we'll answer that question.
Sure.
You can have incontinence in MS for for 2 different reasons. One of them is because the bladder, the bladder, which holds urine, is spasmed down, and it's the size of a racquetball. And you drink half a Coke and you have to sprint to the bathroom to empty your bladder. And that's called neurogenic bladder or overactive bladder. And it's described as an experience of urgency, like move because I'm going to pee in about 10 seconds, whether I can get my pants down or not. It's described as frequency. I just peed 10 minutes ago and I have to go again. I'm getting up 3, 4, 5 times a night to pee. And it's described as incontinence because you can't get yourself settled on the toilet and you start to urinate. And so sometimes you can't get there and you'll wet yourself. The other way that you can have incontinence, though, is a different bladder problem, because that bladder bag then has the urethra, the tube that goes from the bladder to the toilet, out into the world. And the urethra can become contracted and squeezed like a swizzle straw. Imagine trying to drink a Slurpee or a milkshake through a swizzle straw. You wouldn't be able to do it. It'd be really, really small. And so that's a separate problem. And when people have that problem, they have what's called urinary retention, where they can't empty the bladder all the way. And the bladder will fill and fill and fill and fill. And then finally, the pressure in the bladder will be so high that you'll leak and you'll wet yourself. You'll empty your bladder completely. So there can be 2 different reasons why someone has urinary incontinence. And in fact, there's a 3rd reason they can have both, which is called dyssynergy. So they have the first thing and the second thing. And together, it causes a new problem where they have both things going on. And so all of those can cause urine problems. And that's why we have to take a careful history. And sometimes we use a bladder ultrasound tool so that we can assess your bladder and figure out what's going on. Then we know which medicine, because there's a medicine for the first problem and there's a medicine for the second problem. And sometimes we use both if you have both.
Great. Thank you for that. All right. A person, Kristen writes, she had a lot to say, but I'm just going to narrow it down. I have no active lesions right now. However, MS can change overnight, correct? She asks. I heard it is very unpredictable disease. Also regarding COVID, well, we'll get to the COVID one later. Let's go with what you first asked.
So can MS be unexpected? Is that the question?
The changes, what changes
Yeah.
it might have.
So MS is a really fickle animal, and it's really both a chronic and an acute disease, because there is a slow, steady risk of decline in function where you can slowly over time develop problems, and then you can have an acute attack where over a couple hours to days you lose a function. And it's a mental game to come to terms with that. Many patients describe to me waking up in the morning and they sort of do a body check. Can I see out of my left eye? Can I see out of my right eye? My left hand works, my right hand works, my left leg works, my right leg works. Okay, let me try to stand up. And I have to be honest with you, I don't know what that would feel like. I can empathize because I think it would feel horrible, but I've never lived that. And so MS can be unknown. Now, I want to remind you of something that my mentor taught me. I was trained by a great man named Omar Khan, and he used to say, we don't worry about the flat tire we don't have, Aaron. What he meant by that was, you don't drive down the freeway and ask your wife casually, honey, do you think the front left tire blew up? That's not a conversation that you have. If the front left tire blows up, you don't need to ask if it happened. You know it happened, and you pull over on the side of the road and take care of it, and I'm your mechanic. We don't worry about the flat tire we don't have. So I don't want you to be so caught up in being worried about what might happen that you forget to live life. I need you to live your life fully.
Great, thank you for that. Next person, how can I ease muscle pain in the legs every morning?
The fact that you said morning is relevant because the most common muscle pain that we have in the morning is from spasticity. So when you have MS, there's about a 70% chance that you may have muscle spasticity, where muscles get tight. I talk a lot about spasticity on my YouTube channel, and you can check out the details of that if you want later. But suffice to say that spasticity, where you have tight muscles, is always worse under two conditions. Condition number one, it's cold out. And so if the person that wrote in lives in the great state of Ohio, for example, I'll tell you what, man, it is cold out. Number two, when you're still, when you're not moving. And so waking up from sleep, particularly in the north or where it's cold, is a setup for leg spasticity, which can manifest as cramps and Charlie horses or just stiff limbs that are hard to bend and hurt. What do? Stretch. Wake up in the morning and stretch for a good 10 minutes before you exit the bedroom. Do that every morning. Also, keeping yourself warm. So you can't heat the room up to the point where it's like the summertime, but you can use electric blankets or extra blankets and try to keep your body warm. Those two things will help.
Great, thank you. Somebody just told me recently how his he sleeps at night, he sleeps with his legs under covers, and then in the middle of the night he wakes up and his feet are like cramping and like claw-like, and then he was saying that shoots up his leg and goes into his calves, into his thighs, and utter pain, and that's causing him a tremendous amount of lack of sleep.
So that's spasticity, Stu. And sometimes we can really double up the medicines before bed. I'll sometimes use high doses of oral baclofen and high doses of Xanaflex to try to help spasms from occurring at night. Sometimes we have to Botox the muscles of the feet to prevent them from cramping. Sometimes the muscles of the calves have to be Botoxed. Sometimes we put baclofen pumps in people so that we can control their spasticity by going up on the pump at night and then dropping it back down during the day. All of these things are sometimes necessary to manage spasticity in MS.
Great, thank you. Before I go on, I just want to read a couple of comments. Stephanie writes, y'all keep this conversation so real. Thank you very much. And so Stephanie, thank you very much for that too. So I like to shout those things out every now and then. All right, next one is, I lost it. So let's go to this one now. All right, how do you track your immune system changes in between doctor appointments? How do you identify comorbidities which are closely related to MS? Best tips in combating all this.
So I think that we need to clarify the roles of the team, right? Because we're a team. So we're team members. And there are books I read you didn't read, which doesn't make me better or smarter than you. It just means I read some stuff you didn't read. And you're a you expert. You know more about you than anyone on the planet. So I want you to focus on being a you expert. I don't want you to waste energy or time wondering what your immune cells are doing. I can check that with a laboratory if I need to. What I want you to do is I want you to try to live the best life that you can, the fullest life you can, the best you possible despite having MS. And if you get trouble along the way, if there are barriers because of MS, I want you to let me know about them so that I can help you win. So really what I'm saying here is I don't want you to track your immune response. I want you to live life fully. Go get dirty and play in the mud and really engage in life. And then if there's an issue, you come and tell me. The thing that you can contribute the most is what you know about you. And on my end, depending on which medicine you're on, I can check laboratories and I can do things to help you understand, to help us understand the state of your immune system. I got that part.
Great, thank you. All right, I'm going to combine a couple of questions here from different people. At what age would you recommend stopping DMT? What's the average mortality of a woman with SPMS? And how do we know what certain, when do you know like when MS could possibly plateau?
So as we age, the immune system becomes quieter and you're statistically less likely to have an attack, but you're statistically less likely to bounce back and you're at increased risk of progression. MS medicines prevent attacks and slow progression. So I don't want you to stop. Again, I answered earlier, I would stop after death, but before that, I would not. The average age life expectancy of someone with MS is not exactly understood, but when you look at the first line medicines, it looks like either not being on medicine or being on a first line medicine, populations of folks with MS may die 5 to 7 years earlier than the general population. We believe now that we can stave off SPMS and stave probably off early death by using the highly effective medicines as early as possible. The third question was, I forget the third question, Stu. Would you mind reminding me? Sorry.
When might MS plateau?
So definitely at age 80. I think maybe when you get in your 70s, but definitely in your 80s, you're going to see MS kind of plateau out.
Okay. Hopefully we get that far along, right?
Yeah, that's what we want to do.
Right. Otherwise, it definitely will flatten out. Next, right. Next, Cindy says, by the way, we have more than one Cindy, so the Cindy will have to figure out her question. Cindy says, with numbness, is full facial numbness a sign of MS, or is it more indicative of MS only on one side?
So if you ask the question, could MS cause blank? The answer is yes, which means that's a bad question. Now, Cindy, you didn't ask a bad question, but my point here is MS could cause facial numbness, so could like 25 other things. So just because you have numbness, whether it's your whole face or half your face, is not ample enough information to diagnose you. And we have to ask a bunch of other questions, do a proper history, do a physical, maybe do some pictures, MRIs, before we're going to be able to answer that question.
Great. Last one that we're going to do of non-COVID, then I have to get back into them. And because you froze, we get an extra 5 minutes out of you, all right?
Ah, very interesting how you did that. So we'll try to go 5 minutes. Maybe we'll go 4 minutes.
Okay, gotcha. All right. Yiki says, for years I've had the same dull pain many nights and take several hot showers to alleviate the pain. Are there any idea what happens, why this happens only at night?
So it strikes me as very interesting that at night you move less. So a lot of times at night you're still, and spasticity gets worse when you're still, and spasticity is worse when you're cold. And so taking a hot shower would heat up your body. So I'm wondering whether or not some of that pain is coming from spasticity. It's also relevant to comment that at night you're not aware, there's not a lot of other stimulation. And so sometimes people become aware of their baseline pain, which they're not really aware of when they're up, walking, moving, talking, doing stuff. It's not until things calm down that they become fully aware of that. So either one could be going on. We need to ask some more questions to try to get to the bottom of it.
Right. Thank you for that. So Yiki will have to come back with another question. All right. Dr. Boster, is it true if you get a baclofen pump, you cannot get a MRI? And if so, what procedure can you then get?
So that's false. So the company Medtronic Neuromodulation makes a pump called the Synchromed 2, which is MRI compatible up to and including a 3 Tesla MRI. So that's the only pump that I implant in patients. There's another pump called Flomax, and you can't have an MRI unless you remove all the medicine out of the pump, get the scan, then put all the medicine back in, which in my opinion is crazy. And so you can have an MRI with the Medtronic pump. I have a lot of patients with MS that have pumps for spasticity, and they get MRIs once a year.
Great, thank you. And since you're talking about Medtronic, there's a person asking about Medtronic and about the bladder stimulator. Is this the same thing as you were just referring to?
No, a bladder stimulator is medicine by Edison. It's a battery pack with wires that go to your bladder that stimulate it so it functions normally. And make sure that you get the bladder stimulator that is MRI compatible. There's a new bladder stimulator which is MRI compatible. The old ones were not. And so if you had an old bladder stimulator, you could only do an MRI of the head with a low Tesla magnet, which is not helpful. Now with the new bladder stimulators, you can get MRIs. And so ensure that the urologist is implanting the proper device. Otherwise, we'll have to take it out to get your scans, and you don't want to do that.
Great, thank you. And Karen writes, had Botox in both calves months after the quad 4 shot. 2 days later, legs got really weak, slowly getting better. Thoughts for flu shot interaction with Botox possible?
No.
Okay. What are the 2 meds for the both bladder issues?
So there's a bunch of medicines. So when we talk about a spastic overactive bladder, there's a bunch of medicines that are anticholinergics. So if I use trade names, things like Ditropan, Detrol, Myrbetriq, Sanctura, these are Tripsium, these are excellent medicines that work to open the bladder. The medicines that we use for the bladder neck are different. So Flomax is the one that I use the most, which is off-label. Flomax was invented for men's enlarged prostates, but both men and women with MS that have a bladder neck that's tight respond when they take Flomax, it opens it back up. So those are the 2 big categories of medicines. There are others, but those are the main ones.
Okay, great. So in case anybody lost count, I went more than 2 asking questions about before getting into COVID. So now let's get to COVID, okay? All right, I know some people who have died from COVID because they developed sepsis. Does our immune suppressing treatments put us at more risk of COVID and more risk of sepsis?
So my understanding of COVID is not complete, but the biggest risks are a respiratory compromise where you have what they call COVID pneumonia and you can't breathe. Or what we're learning is that it can cause a hypercoagulable state. So you can have strokes and heart attacks and pulmonary embolisms and clots like that. So those are the biggest areas that we're seeing death, to my understanding. I'm not as familiar with it causing sepsis, although sepsis is a severe outcome of any infection if it gets in the blood and goes unchecked. Now, if you're on an immunosuppressant, you may have a harder time of fighting off any infection. I'll share with you anecdotally that I've had several patients on serious immunosuppressants that got COVID and cleared it easily. And I've had patients that have not been on immunosuppressants that have had hospitalizations and some of them intubations. And so I don't think we can make sweeping generalizations except to say, if you're on an immunosuppressant, I want you to be more secure about distancing and washing and masking and all that important stuff.
Okay, great. Thank you for that. And several people have written in asking, with regard to the new vaccines, live or dead. We hear about this constantly. Would either, yeah, and just one more thing going further, is there would it be known for a person with a progressive form to take this vaccine?
So the real answer is we don't know, Stu. There's a lot that we don't know yet. It looks like the vaccines that the 3 companies are putting forward are dead, but I want to make sure and read through it before I say definitively. Now, whether you have relapsing MS or progressive MS, you're still a human being and you're still at risk of contracting this novel coronavirus, and I would vaccinate you.
Great, thank you for that. All right, next one. Let me skim up a little bit because I did have more. And by the way, for everybody that's on here, and we, like I said, we do have a lot of people. We do have a lot of questions out here. Dr. Boster is running out of time for tonight. He also did a live stream before this event, so he's been a little bit busy today. But Dr. Boster will be back with us next Wednesday night. Okay, next Wednesday we have, excuse me, not next Wednesday. He will be with us next Wednesday. But even on Tuesday, where we have Dr. Ronnie Boroshed from where is he? From Michigan. Yeah, that one, Oswaso or something like that. You got it. And so he will be on, and as well as Mindy Eisenberg, who's the yoga master. They will both be on there that same night. In fact, at around 9:30 tonight, you're going to be getting an e-blast from me telling you all about that, and it's for you to get registered. But like I said, Dr. Boster will be back with us next Wednesday night. So whatever questions we don't get to tonight, I am going to have saved, even from what you guys were asking online. I will have them saved, and we'll make sure that they get answered next week. All right, now I did see an interesting one from a person. All the questions are interesting, but this was different. And Elaine is stating that with 6 different pharmaceutical companies making and releasing a type of vaccine, do we ask for a specific farm company, or do we just get what vaccine that will be given to us?
We don't know yet. We don't have enough information to know the answer yet. I can't tell you yet.
Okay. All right. So we're done with that one. And then let me just see if there's anything else out there that's COVID related. And, you know, like I said, there's a lot of questions here. So, yeah. All right. So people, again, wanting to know about gathering in groups, especially with Thanksgiving being here. You did say something at the beginning of the program, but a lot of people didn't get signed in right away. So if you can repeat what you said at the beginning of the program, that would be great.
Right now, there's a spike throughout the country. And in central Ohio, where I live, there's a massive spike in cases and in deaths. Deaths have been in double digits in Columbus for quite some time now. And when you look at the increased cases, they're not coming from large gatherings, you know, big crowds of people for concerts, or because those things aren't going on. They're not happening because you have hundreds of people in a movie theater, because that's not happening. They're happening because of small family gatherings. So gatherings of people for a wedding reception, or gatherings of people mourning the loss of a loved one who's died at a funeral, or small parties. People are getting their loved ones sick, not on purpose, because you can have coronavirus, you could have COVID-19 and not manifest symptoms at all, or it could lay dormant for 2 weeks before you start to have symptoms. That's why I'm not going to Thanksgiving dinner with my mother. My mom and her husband are in their 70s, and I don't want to risk bringing something to them by accident. I am a doctor in a clinic, and I've seen patients with COVID today, and I use as many precautions as I can, but I'm not going to risk infecting my mom. And I think that's a really big deal, and I want you to take it seriously as I am. And I strongly recommend that you do not gather in groups. I strongly recommend that you don't have a celebration for the holiday tomorrow outside of your nuclear family, the people that you live with. So I'm going to be celebrating with my wife and my 2 children here in my house, and we're going to Zoom our relatives. And I think that is the safest option for my family and for me. And I certainly think it's the safest option for you and your family.
Great. Thank you very much. And so, not wanting to take up any more of your time, I know you're a very busy guy. You have to get up early in the morning and go treat more patients. So for everybody, again, that did not get their answers, their questions asked tonight and answered, even if I don't remember to write them all down, please write them down yourselves and bring them to our next event. Again, I don't want to tie up any more of Dr. Boster's time, and we have to respect him. I mean, he speaks for us many times per year, right?
It's a great pleasure, and I'm looking forward to next week. So jump back on next week. We're going to be talking about new things. We're going to answer all new questions, and it's going to be a really great opportunity. Stu, I'm looking forward to it.
Thank you. Thank you very much. And everybody, thank you. And let's again thank Bristol-Myers and Biogen for supporting tonight's event. and we go forward, and we will be here. MS Views and News will be here to bring you as many virtual programs as we possibly can. And we are now up to getting, in January, up to 8 per month. Okay? There you go. Rock 'em.
Take care, guys. Have a wonderful
Have a great
night.
night. Namaste.